Thank you for joining us for Talking Sleep, a podcast of the American Academy of Sleep Medicine. I'm your host, Dr. Seema Khosla, Medical Director of the North Dakota Center for Sleep in Fargo. Today's episode is sponsored by Apnea. A few months ago, we had a discussion about wake-promoting medications to use in well-treated obstructive sleep apnea. This led to a conversation about what we mean by well-treated obstructive sleep apnea. Is this based on the residual AHI on a download? Is this based on a titration study? What about those who get better on sleep apnea therapy, but not all the way better? Should all of these patients undergo actigraphy with PSG and MSLT? How do we define what well-treated obstructive sleep apnea is? Dr. Barry Krakow is a sleep medicine physician who did a study years ago on patients with treatment-resistant insomnia. He found that 85% of his cohort had undiagnosed obstructive sleep apnea. He also wrote on the use of ASV for upper airways resistance syndrome and is here to share how he looks at patients with sleep apnea who remain sleepy despite being treated with PAP therapy. He is the director of sleep medicine at the Gateway Behavioral Health Psychiatry Residency Training Program and joins us today from Savannah, Georgia. Welcome. Thanks for joining us today.
Thank you for having me. I love talking about sleep.
So you reached out after listening to the episode on the use of wake-promoting medications in well-treated obstructive sleep apnea, and I thought you brought up a really interesting discussion point. How do we define what well-treated sleep apnea is? So this led to a conversation that we've been having over email for a few months now. So tell me your thoughts on this. How do you define well-treated sleep apnea?
Well, we've embraced the personally tailored approach to sleep medicine as more and more doctors are doing so in healthcare in general. And in doing that, we were surprised how many people we saw, for example, coming in using CPAP devices to our center and yet still having lots of complaints. And that is back in the early 2000s. And so what happened was that particular pivotal moment when we saw people not doing well with CPAP and we switched them over to more advanced PAP therapy devices, for example, bilevel, auto bilevel, whatever. And then suddenly they were so much better. It gave us an understanding of the concept of ceiling. Okay. In other words, when somebody gets better, like, is that as good as they should get? Or is it really just a ceiling because that's all the better that they know? So that was really what started this ball rolling, because we realized that people who were on PAP therapy had a very difficult time trying to assess their own experience with the results, because they would just say better, but well, how much better should it be? And I would add personally, I've been through the same thing where I've been on a PAP machine, CPAP, thought I was doing really well. And then when I switched to bilevel, I said, wow, this is very different. So this immediately raised the question in my mind, what is the endpoint? What's the ceiling for people? And that's why when I saw the wake promoting research coming along over the last 20 years, last 10 in particular, I got very curious about this, wondering like, well, how are they treating these patients and what are their endpoints that make them say, this is where to go, that is, medication, versus saying, hey, let's put him back in the sleep lab.
So that's really interesting that you still kept them on PAP therapy. You didn't switch to maybe an oral appliance or something because they were intolerant, but you switched the modality. So did you notice a difference then? Was it that their residual AHI was higher than 5 before? Now you got it below 5?
Absolutely. If you think about the way pressurized air treats the breathing events, an apnea is a closed airway and it only needs a little bit of pressure to treat it. And once you treat it, it turns into a hypopnea. And then once you treat that hypopnea with, again, more pressure, you now turn that into what? Is that normal breathing? Well, in our clinical experience, no. As you know, I trained with Christian Guilleminault and learned a great deal about upper airway resistance. And so it wasn't that the AHI was the big issue. It was the RDI was persisting. And these people were having tons of flow limitation. And when we saw them in the sleep lab on CPAP, and we couldn't effectively treat flow limitation with CPAP, we ended up switching to bilevel, efficaciously treating the flow limitation, and people got better, noticeably better. And so that was the pathway we started in 2005.
So it's not necessarily just increasing the pressure, right? You kind of brought them into the lab then and you titrated for flow limitation?
Well, that's a great point, because with bilevel, what are you doing? You're both raising and lowering the
Right.
pressure. The problem with CPAP, which we've written about, and it's been described in some of the guidelines from the ASM, is the fact that pressure intolerance, in our understanding of it, is a very big deal. Keep in mind, we spent a very long time, even to this day, with most of my work and coaching work and research, I'm working with mental health patients who have anxiety and sleep disordered breathing. They're incredibly sensitive to all of this, and they are extremely sensitive to the use of CPAP. CPAP gives them a very pronounced expiratory pressure intolerance, and therefore you can never raise the pressure on CPAP high enough to overcome the flow limitation. That was the critical point of how we ended up seeing the need for this change. We were sitting in the lab looking over studies with our sleep techs, and we kept noticing these funny squiggles on the expiratory limit of the airflow curve. And we noticed that if we switched somebody to bilevel, we could get that airflow curve to look normal on expiration, and we could raise the pressures so that with bilevel, the flow limitation would be corrected in the terms of the problem of UARS. So that was very instrumental in seeing this. We were looking at and say, this is happening in patient after patient after patient. We published a paper in 2013 describing how ASV was very good at treating flow limitation in UARS patients, and at the same time showing that before ASV they were on CPAP and they had all these signs of sleep fragmentation when they tried using CPAP.
So, do you think that this is a phenomenon that we see more in people who have PTSD or other mental health disorders, or do you think this is something broadly applicable to all of our patients with sleep apnea?
So a great answer to that question would be yes, because it turns out this is how we learned it from the mental health side of it, but really there are a fair proportion of patients in the general population who, let's just call it a degree of anxiety sensitivity without necessarily having a diagnosis. Those people get very frustrated using CPAP. They develop this same pressure intolerance. It's very difficult to get a normalized airflow curve with them. So I do think it is broader than just the mental health community, but that's where I learned about this problem so acutely and where I've seen it so widely. As I mentioned, we literally stopped using CPAP in 2005 and were able to work with our insurance carriers, medical directors, and so forth, explaining our new model. And they were all for it. So we were very fortunate back then to start then, because now people have much more difficulty working with insurance companies on switching devices.
So that's kind of impressive. So meaning you only script ASV and bilevel PAP now?
Well, right now I'm in a different area because I'm in Savannah, Georgia. But when I ran my sleep center for the 16, close to 20 years,
Okay.
the period of 2005 to 2020, right around 2006, 2007, we started ringing up every medical director we could find: United, Medicare, Cigna, Blue Cross, local insurance systems. And we had a lengthy talk with them. We would send them some research papers. We'd send them diagrams. We'd say, look, CPAP is a really important thing. You want your patients to use it. It's going to save you a lot of money, but they can't use CPAP. And by the way, we're spending a lot of time working with PTSD patients, anxiety patients, and we have discovered that they do so much better with these devices. And so once we did that, this was phenomenal. During that stretch of about 15 years, we never had one rejection of anybody getting prescribed bilevel or ASV until around 2019, when United came along and started saying, no, everybody has to start on APAP. I don't care what you do in the lab or not. You have to start on APAP. But that was the beauty of this. when you bring an individual back into a sleep lab and you titrate them with CPAP and you demonstrate several things: expiratory pressure intolerance, the failure to overcome flow limitation, other signs of arousal and sleep fragmentation, and a big one was the inability to go into REM sleep. We found this just so consistently. What I just described to you amounts to a category that can be called CPAP failure.
Mm.
And you can put that into your titration report and say, for this reason, we switched the individual over to bilevel. And that is how we got most, 60, 70% of our patients were on bilevel. It was only later, after ASV got in the picture, about 1/3 of our patients met criteria for ASV, or we persuaded the insurance company this was the best device for the patient, regardless of the central apnea aspect.
So that's really interesting, right? One, that you define CPAP failure a little bit differently by them not entering into REM sleep. And two, that you could get ASV. I mean, that's really impressive.
Well, we published on this, and we had hoped that insurance companies would read the information and see what we were talking about, because there is a problem in our field today, as far as I can see, where people are spending too much time worrying about CPAP compliance and adherence, which is really not about efficacy. When you say CPAP failure is a new term, if you really think about it, it's not. It's really defining what we've all used in medicine for years, which is your treatment working or is it not? If your treatment is working, well, it's a successful treatment. If the treatment is not working, it's a failure. So when CPAP is not solving the symptoms of the individual, then that is a case of CPAP failure. And some of the symptoms could be the patient doesn't clearly have as much REM sleep. They're not consolidating the REM. They're still going to the bathroom at night. They still wake up and don't feel that refreshed. During the daytime, they don't feel their energy is as good as it should be or as what they thought it should be. The list goes on, and that goes back to your original question. And I would just say that asks the very interesting question of, well, what is normal sleep? Does anybody even know what that is?
So let's take a short break, and when we come back, we'll talk more about how we define well-treated obstructive sleep apnea. You're listening to Talking Sleep from the American Academy of Sleep Medicine.
Dive deeper into the future of sleep apnea therapy with the Apnea Sleep Care program. Once we receive the PAP referral, our team springs into action, offering patients a seamless transition into therapy. Patients start by selecting how they want to begin their sleep journey: in-person care, virtual care, or self-directed care. With ongoing therapy support, including coaching, digital resources, and video assistance, we're committed to ensuring every patient's success. We stay connected with our patients with live calls, texts, emails, and IVR, all designed to make adherence a breeze. And with our supply schedule program, replacements are delivered like clockwork. Experience the difference of an enhanced sleep therapy program with Apnea Healthcare. Discover more about our innovative sleep program online today at apnea.com.
Welcome back to Talking Sleep. We're talking with Dr. Barry Krakow about how we define what well-treated obstructive sleep apnea means. So talk to me about the relationship between upper airway collapsibility and anxiety.
So there was a research paper that was done in 1994 by, I think, a Dr. Series, where he took normal sleepers, put them in a sleep lab, and rang a bell tone 300 times during the night. These are perfectly normal sleepers. When they woke up in the morning, they felt awful, and they said to the doctors, the researchers, "What did you do to me?" Because they're normal sleepers, they just slept through the bell tones, right? Okay, so they had fragmented sleep. So this was a research project on sleep fragmentation. So it turned out the very next night, for whatever protocol reasons, they wanted to test these people again after their one night of sleep fragmentation. And what did they find? The amazing finding of airway collapsibility. They actually had measured their airway with, I think it's something called, I don't know if it's a tachometer a pneumotac.
Okay.
And they actually demonstrated that from baseline numbers to after sleep fragmentation, they had greater collapsibility. Now, if you look at the scientific literature over the last 30 years, everybody cites that paper asking this one question. Does that mean that if you fragment somebody's sleep, you're actually going to make their breathing worse? And so now you have this whole cohort of individuals that have been coming up with this idea that PTSD, which causes tremendous hyperarousal and sleep fragmentation, whether it causes sleep disordered breathing. And so that's where this idea came to us about the idea of anxiety, because when we were doing PTSD research starting in the 1990s, we were shocked at how often they had sleep apnea. Now you could say, well, wait, it's a biased sample. They come to a sleep center because they have sleep problems. But remember, they didn't come to the sleep center because they were snoring. They came to the sleep center because they had nightmares, because they had insomnia. And they didn't know they were going to get a sleep test and find out they had sleep apnea. That was the last thing on their minds. So learning about all this in the mental health community was really startling. And obviously we had to ask the question, are mental health disorders causing people to have some change in their airway collapsibility? We don't know the answer to this day. It's something that nobody has really researched in a way that would give a definitive answer. But the number of sleep breathing problems in the mental health community, anxiety, depression, and PTSD is astronomical and is going to dramatically affect the way psychiatry has to be practiced in the future.
Well, and it reminds me of a study that demonstrated that military veterans with PTSD had the highest risk of having sleep disordered breathing.
Right. Well, our studies, preceded that. We published many studies in the 1990s and the 2000s, either showing that there was going to be a risk or actually demonstrating high rates. I was on one of the papers, on the military population.
Yeah.
There's been multiple papers now. Everybody is in agreement now that the rate of PTSD in people in the military, sexual assault survivors, those particular groups, is just outrageous. And it's clearly a part of their PTSD. Whether you call it comorbid or not doesn't really matter. It is part of the problem. And I'll tell you, there's a major study that was published out of Long Beach, VA just recently. It's phenomenal. It showed that if you take a group of people undergoing what's called exposure therapy, which is one of the main treatments for PTSD and the most evidence-based treatment for PTSD to this day, if you divide the cohorts of the people who got exposure therapy and were using CPAP for their sleep disordered breathing, they responded to exposure therapy. Now look at the cohort that had untreated sleep apnea, not using a CPAP. They still got exposure therapy. They did not respond anywhere near the level of the other group.
Wow.
That's
really interesting.
That's how big this is. And the mental health community is not embracing it yet because it doesn't know how to. Because all those people out there that they're treating for PTSD, so many of them, I don't know that it's all of them, I shouldn't have used that term, but it's so many of them have post-traumatic stress disorder and comorbid sleep apnea. And that sleep apnea is absolutely impairing them by causing nightmares, causing insomnia, and of course making anxiety, depression, and PTSD worse.
So this kind of makes me go back then to the initial question about when to initiate wake-promoting medications, because it sounds like before you even consider this, that you would put them in the lab and make sure you're treating their upper airways resistance. Am I understanding that correctly?
Absolutely. And like in my career, I've only used wake-promoting agents in that situation in a handful of patients. Nearly all of them got much better results by going on auto bilevel or ASV. In general, auto bilevel would comprise 2/3 of our patients, and ASV would comprise the other third. And these people were getting outstanding results with one caveat. and this is relevant to some of previous podcasts you had with Dr. Winkleman, we actually have seen some of these patients who still have the leg jerks causing arousals, and so we ended up treating them with medication, and that was what helped them get to that place. Now, yes, there absolutely are people that you do all of these things, and yet there could be a reason to consider wake promoting agents, and we did. But as I'm saying, that it was a very small number in our sample. I don't operate a sleep center right now. I work over at the Gateway Behavioral Health Psychiatry Residency Training Program, where I'm working with psychiatry residents, teaching them this information about sleep disorders.
So then, do you ever start wake promoting medications before their sleep apnea is fully treated?
Well, when I was practicing in that model, I would never do that unless I was treating a narcolepsy patient.
Huh.
But in that setting, it is so interesting that we saw back then, and then the research now is coming out, that nearly all narcolepsy patients have sleep apnea, and many of them have restless legs and leg jerks. And so everything I'm understanding about the field is saying that narcolepsy patients get their anti-sleepiness drugs or wake-promoting agents, but they also should be treating their sleep apnea, and they should also, in some cases, be treating their leg jerks. And I was impressed that that was the evolution of that model over the last few years of our practice when we were in Albuquerque.
That you would fully treat their sleep apnea before wake promoting medications?
Oh, no, not in a diagnosed narcolepsy patient.
Okay.
We would absolutely start there. But the one where it's the trickiest, and so I'm so glad you're asking the question, were the idiopathic hypersomnia patients, most of whom, obviously, you can imagine from my perspective, turned out to have UARS. And we would put them on these advanced PAP machines, and very few of them ever needed wake-promoting agents. Most of them needed a much more advanced form of PAP therapy, and then they had a tremendous response.
Your cohort of IH?
Yes.
Huh.
Now, see, you're surprised, but see, that's been in the scientific literature, and Dr. Guilleminault talked to me about this 30-some years ago, that there are patients, and in fact, he was the one who made the discovery in 1973 in Bologna, Italy, as a neurology resident, linking sleep apnea to insomnia. Fast forward, 25 years, we published our paper on complex insomnia. That was the name we coined for all of these people who had the combination. And he was pointing out that the sleep breathing problem is just so pervasive that you really always have to look for it. And that was absolutely been proven to be the case in many IHS cases among those doctors who actually practice that way. But there's many practitioners who don't look at that. They don't look at the flow limitation in an IHS patient and instead give them wake promoting agents.
So I feel like, though, that since now we can use oxybates for IH, and we know that oxybates can make sleep apnea worse, I feel like there are a lot more IH patients who are on PAP therapy, either because they developed more airways resistance on an oxybate, or maybe they had it before. But I feel like that is another consideration, that part of the treatment may be worsening their sleep apnea.
Yeah, it's a great point. That's a great point. It goes back to something I've written about, and this is like parallel to what you're saying, but I completely agree with what you're getting at. Let me ask you this question. Should somebody get a sleep study before a doctor prescribes a sleeping pill? What's your thoughts on that?
Ha! It's funny because I think, we've all seen a lot of paradoxical insomnia, right? We've seen a lot of people who swear up and down that they don't sleep at all, right? But objectively, they have some sleep. I think it's challenging. And the reason I think it's challenging is because then you are bringing them into the lab and you're putting all the wires and you're making it harder for them to sleep. So is that sleep study going to be valuable?
Well, first of all, there's always the first night effect, and
Right.
lots and lots of chronic insomniacs do come to a sleep lab and they do sleep. And when you see what they're doing when they're sleeping, you discover very quickly that a very, very large number of people who have the problem of chronic insomnia have been living with that condition for 5, 10, 15, 20, 30 years. All the drugs in the pharmacotherapy model have been thrown at them. Sometimes they work, sometimes they don't. I'm not saying that those drugs can't work for some patients, but this track record is so poor, it should be obvious to sleep doctors by now that most chronic insomniacs who are on sleeping pills probably have a sleep breathing condition that is a much more important component to what is going on with their sleep. And we published several papers on treatment-resistant insomnia after the original complex insomnia paper in 2001. We published a couple more papers showing rates of 80, 85, 90% of treatment-resistant insomnia patients really do have sleep breathing. And keep in mind the word treatment-resistant is a little bit peculiar, because basically if you ask a chronic insomnia patient how their sleeping pills are helping them, you are not going to hear these results about, oh, they're fantastic. I just can't believe how great they are. You do hear that in a few people, but you do not hear that in the vast majority. Why? Because underneath there's a physiological problem. And that physiological problem in most instances is a sleep breathing problem combined of both hypopneas and flow limitation in most cases.
But then it's also a really tough group of patients to have approval to do a sleep study for.
So again, that goes back to something we dealt with in 2005. I don't know if you're old enough to remember this, but the American Academy of Sleep Medicine initially had guidelines that said, if you have insomnia, that's an indication for a sleep study. Unfortunately, the American Academy of Sleep Medicine removed that terminology from its guidelines for reasons I'll never know. Yes, absolutely, though, you can get sleep studies on insomnia patients very easily, because all you have to do is ask other questions. Do you wake up at night to urinate? Do you wake up with a dry mouth? Do you wake up with a morning headache? Are you tired and sleepy during the day? Do you have non-restorative sleep? Bingo, you're set to go. Absolutely, you can get a sleep study.
Sort of, right? Because we still have patients that won't check all those boxes. But your point is taken. I get that.
But hold on. If they don't check those boxes, then I'm of the opinion, well, maybe they don't have sleep apnea. Okay. I'm saying so many insomnia patients even have some breathing issues. So many of them have these issues that are not the typical way you work up a patient for sleep disordered breathing. Because I work with mental health patients, we stopped thinking about breathing symptoms. We didn't even care about them. We said, tell me about what is your sleep like? Do you feel good when you wake up in the morning? Absolutely not. So these mental health patients are describing non-restorative sleep in spades. If that's what they're describing, why should I imagine something unusual like, oh, well, your bad sleep quality is all about your depression. Oh, it's all about your anxiety. That's nonsense. Those disorders do not create the degree of physiological sleep fragmentation that sleep disordered breathing does. And so this is something that the mental health community is like having to cope with, because they don't understand sleep and they don't understand sleep quality. We're very fortunate. We're sleep doctors. We understand everything about sleep quality. We just have to attach the two. Right. If you've got signs of non-restorative sleep, then by all means, you need a sleep study.
2025 marks the 50th anniversary of the AASM. Here's Dr. Tom Roth telling us about the early days of establishing a sleep society.
The main issues was, when you start a new field, the question really becomes, what are the standards? What are the standards? What is an adequate workup for patients with sleep apnea? When do you do MSLTs? All the things which, as the society matured, had position papers, we had a struggle. So, you got to remember, so we said we sort of had people going out and doing accreditation centers. So one of the things that we were very interested in, what are the site visitors going to look for? So I'm going to go visit Columbus. What do I want to do? One of the things that was very important is in those days, sleep centers, were a little obscure. We wanted to know if I'm a patient and I'm going to Montefiore for a sleep study, am I going to be able to find it? A sleep clinic's under the Directory of Clinical Services, so we're very interested in things like that. We want to know the qualifications of the technical people, the qualifications of the medical people. They had to have somebody who passed the sleep boards. They had to have technologists who were trained, because then there was no accreditation of technologists. But it was understanding what personnel was necessary, what the facilities had to look like. I mean, you got to remember, like in the Mayo Clinic, sleep studies were originally done in a hallway on gurneys. That clearly would not have made, if a site visit was done at that point, it wouldn't have been good.
Now back to our conversation. So then tell me about your patients who have PTSD and how you help them get used to PAP therapy.
So in the beginning phases, when we were still using CPAP, we actually learned a technique from my nightmare treatment research that used a technique called imagery rehearsal therapy. And that is right now the first line non-drug treatment for the use in the treatment of chronic nightmares. So it turns out imagery distraction is an extremely powerful technique to help anybody who struggles with PAP. And it simply means that instead of trying to harmonize with a pressurized air, or paying attention to it, or paying attention to your mask even, you want to be in your mind's eye on a beach in Hawaii. And you want to hear the waves, and you want to see the seagulls. And it turns out that if you teach somebody to use that model of mind's eye distraction, it will take their focus off of pressurized air and the mask itself, and people learned how to do that. We actually taught them that in the sleep lab during the first titration they would undergo. The sleep techs would train them in this technique, or I would have trained them earlier in a clinical appointment, or both. Now, the interesting thing was we got a fair amount of PTSD patients to use CPAP or auto CPAP, but that's around the time that we discovered this problem with the expiratory pressure intolerance, and we switched them to bi-level and found, wow, this is so much better. And so when they were on bi-level, the comfort was there with one caveat. If a person tries to get used to bi-level by harmonizing with the breathing in and the breathing out because it's different pressure settings, that can actually make it intolerable. The person is like paying too much attention. So in psychiatry, the term is called somatosensory amplification or attention amplification. And what that means is the individual can't stop thinking about the thing on their face or the air pressure coming in, and it drives them nuts and they rip off the mask. So imagery distraction worked when we used CPAP, but with bi-level, we didn't need as much imagery distraction because the bi-level was so much more comfortable with that one caveat. If they pay too much attention to the air getting higher when they breathed in and getting lower when they breathed out, then that would create the anxiety in this problem, called attention amplification.
That's a great term. I didn't know there was a word for that. I'm going to park that in my brain.
My career was all about working with psychiatrists. I mean, in 1988, when I started in the field of sleep medicine, research doing nightmare treatment, I worked with 2 psychiatrists. From 1988 to the present, everything I've done in sleep medicine has always been something to do with working with the mental health community. So I learned all the terminology.
So, this reminds me of a conversation we had with Dr. Danny Eckert and endotyping obstructive sleep apnea. And he kind of talked about these different endotypes. And one was patients who have a low arousal threshold. And of course, then that led to this conversation of, do you start hypnotics? Like, how do you kind of address that? So do you empirically start hypnotics in your patients?
Almost never.
Okay.
In my clinical experience, people were always coming to us saying, can you get me off pills? So I was dealing largely, because it's a mental health population, they have anxiety, depression, PTSD. These people are on tons of pills, 2, 3, 4, 5 pills at a time. Their question was, can you help me to sleep better in a way that I can use less medication? So that was the number one goal that they would have. Now, I think where the question is more pertinent is, what about a person where we say to them, look, you're on all this medication, but let me tell you, this problem of sleep apnea that you have, it didn't start yesterday.
Right.
Your doctors didn't understand this phenomena. You've probably had the sleep apnea bugging you for 10 or 15 years, and it's been fueling part of your mental health problems, clearly part of your insomnia problems, even in some cases part of your nightmare problems. So the question is, what do you want to do about it? Well, it turned out many of these people were so excited, and this is a very important thing for sleep doctors to appreciate. If you're working with a mental health patient, for years, they've been stigmatized because they have to deal with this idea that they have something wrong with them mentally. And they go through various stages of how they're going to treat it. Many of them don't treat these things. But when you come along and you say to them, I want to do a sleep study because I think you might have sleep apnea, and then you show them they have sleep apnea, this is an absolute miracle. This is a godsend to them. You're telling them that some of their problem, not all, but some of their problem is physical. This is absolutely music to the ears of people with anxiety, depression, and PTSD. Yes, there's a few people like, oh, I have another problem. What do I do now? But for the largest majority, it's, wow, you're changing my life. You're saying that what's going on in my brain, which is fragmenting my sleep, is actually part and parcel of my mental health problem. I say, absolutely it is. And there's already research showing that when you treat this sleep breathing problem, there's a chance you can improve your nightmares, your insomnia, your depression, your anxiety, your PTSD. It's all in the scientific literature already. It's not at the level we want to see of the literature, but it's all out there. And clinically, many, many doctors now are seeing these kinds of results. So what I'm getting at with this lengthy background is that they want to try PAP therapy. And so they're now eager to try bilevel or ASV. And we ran them through the sleep lab and showed them that they had CPAP failure. They got on bilevel. It was more comfortable. And keep in mind, 90% of these patients never had to fill a CPAP prescription because we had spoken to their medical directors about how they wanted to deal with the insurance. And they agreed with us that if we could show this CPAP failure concept in the sleep lab,
Right.
then they were willing to let the patient be prescribed bilevel. And we have rates of, we published a paper in 2017 showing that 90% of PTSD patients were using their PAP therapy at 6-month or longer follow-up.
But but you're just redefining what CPAP failure means, right? Because that's always been, and usually it's pressure intolerance or something like that, but you're adding a qualifier about, oh, they didn't go into REM or their sleep is still fragmented.
Well, the big one that I'm qualifying it in is that it's a failure to achieve the result that we keep telling them that you're going to achieve, even if you're just a regular, quote unquote, regular sleep doctor treating quote unquote regular patients, of which I don't think there are any. But the point is, you should not be so sleepy. You should not be so tired. You should wake up refreshed. You should say that you feel like your sleep is really consolidated at night. You should say that you remember dreaming during the night. All of those things we should have been asking all along, because those are part and parcel of people who sleep normally. And so if that's what a normal sleeper is doing, and I'm treating you with this condition called sleep apnea, I certainly want my target to be getting you so much better that you feel like your sleep is something close to normal. And so I'm not going to start with, oh, you're tired and sleepy during the day. Okay, well, here's a pill. That's not going to happen.
But I think there's also something that you mentioned earlier about how the referring physician didn't look at their sleep. And I don't think that's because of malintent. You know, we always want to assume good intent, right? But I think it sort of highlights this importance of that sleep apnea can have many faces.
Right.
And it's important for us as sleep medicine clinicians to, you know, share that with our colleagues, you know, that not everybody with sleep apnea is obese, right? Not everybody with sleep apnea is older. And
well, you hit the nail on the head. I mean, I just saw a patient just a couple of weeks ago where the patient was not obese, and the doctor had said to the patient, well, you don't need a sleep study. And I said, are you kidding me? Kushida did a paper in the 1990s actually demonstrating that it is your airway that is the major factor that determines whether or not you have sleep disordered breathing. In fact, technically, obesity does not cause sleep apnea. It literally worsens it by adding tissue, fat tissue in the airway. But almost all the people who are obese, as far as I can tell, probably had sleep apnea before they became obese. And I would speculate wildly that the sleep apnea had something to do with how they became obese.
Yeah, and I think there's a fair bit of data to support that, right? That maybe the sleep apnea came first and disrupted sort of the satiety and hunger signals and that sort of thing.
Yeah.
And I think that is an important conversation because I think with obesity, there's a lot of blaming and self-blame, right? And patients come in every day saying, gosh, if I could just lose this weight, I know my sleep would be better. And they absorb all of that blame, right? And sort of recognizing this objective, hey, you know what? Maybe the sleep apnea came first.
Yeah. And the thing is, unfortunately, that model that you just described was talked a lot about by a lot of doctors about, I think it was about 20, maybe even 30 years ago. And a bunch of, I would call it, really, I'm just going to flatter them. There was a bunch of doctors who were outliers when they heard that theory. They said, and you'll love this, they go, how do you know the sleep apnea, when it's treated, won't make them gain more weight? And everybody threw out their arms like, oh, what do you mean? Why is that going to happen? Well, as it turned out, there's not really good research showing that when you treat sleep apnea with PAP therapy, that you lose weight. Mm-hmm. Obesity is an unbelievably complex disorder. I would hope to write a book on it one day if possible, because there's a researcher, I know we're getting far afield here, but you'll love this information. There's a researcher, Vincent Felitti, who wrote this work about obesity and PTSD years ago and demonstrated that obesity in the largest proportion of patients is directly tied to a trauma history. And unless you actually do something to work through that trauma history with the patient, that obesity will go back and forth like it does in most patients and will never come back to normal. Only those people that get some certain types of psychotherapy that help them deal and process with that trauma do they show the most long-standing results of obesity reduction. Mm. And unfortunately, the information I'm describing to you is only used sparingly in conversations with patients who undergo bariatric surgery.
I wonder if the GLP drugs are going to change that.
Some, but I think they're going to discover lots and lots of side effects with that drug, and I think they're going to discover this particular issue of what's called emotional eating, which is what the trauma literature is talking about, still has something to do with what's going to go on with those patients. That would be my speculation.
So we've covered a lot of topics. Do you have a key takeaway for us?
The thing that I want to harken back to is what you said about the many faces of sleep apnea. I have been so surprised in my career. I've seen cases I never, ever would. There's been cases where I would say to the patient, look, I can tell you right now, there's no chance you're going to have a sleep apnea of a sort that is going to be covered by insurance. But if you want me to do a sleep study and find out if you have one of these incredibly subtle flow limitation patterns, one of them is called sustained flow limitation, where the numbers just don't add up. And I've seen cases like that and treated the patients with PAP therapy, and their lives are miraculously changed. And it's not a placebo effect.
Right.
It's not. These people have been on it for years. So the key takeaway is, when somebody's telling you that it's just not getting a great response, whether it's an insomnia patient or a classic sleep apnea patient, think that there's more that you can do in a sleep lab to evaluate them. That's what we did for 20 plus years, and we helped a lot of people by bringing them back to the sleep lab. I know that's harder to do nowadays, but working on that model of objectively looking what's going on in their sleep, there is an absolute goldmine of information there that will help your patients.
Well, thanks for joining us today and sharing your thoughts about what we mean when we talk about well-treated obstructive sleep apnea.
Thanks for having me.
Thanks for listening to Talking Sleep, brought to you by the American Academy of Sleep Medicine. For more podcast episodes, please visit our website at aasm.org. You can also subscribe through your favorite podcast service. And if you enjoyed this episode, please take a moment to leave a rating or review. For more feedback or suggestions, email us at podcast@aasm.org. I hope you'll join us again for more Talking Sleep. Until next time, this is Seema Khosla, encouraging you to sleep well so you can live well.